Good morning to all. The topic for today's discussion is halitosis. So, in general, halitosis it is defined as an unpleasant or offensive odor emanating from the breath, regardless of whether the odor originates from oral or the non-oral sources. So, there can be two sources, that is the oral or the non-oral sources, from which the oral malodor it comes from. It was described as a clinical entity by Ho in 1874. Now, the halitosis, it can be termed as other names it has, that is a bad breath, breath malodor, oral malodor, and fetor ex ori. Now, coming to the classification, it has been classified into three, that is the genuine halitosis, the pseudo halitosis, and the halitophobia. Genuine halitosis has been further classified as physiological halitosis and pathological halitosis. The pathological halitosis is further divided into oral origin and the systemic origin. Now, understanding the etiology of halitosis, so there should be the presence of bacterial decomposition of the food particles, cells, blood, and some of the chemical compounds of the saliva. Now, there should be the presence of volatile sulfur compounds. Those are the hydrogen sulfide, the dimethyl sulfide, methyl mercaptan. These are the volatile sulfur compounds due to which the halitosis is present. Then the next compounds are the polyamides, that is the putrescine and the indole, and the other compounds are the acetone and the acetaldehydes. Now, understanding the pathogenesis of oral malodor, whenever there is a presence of food particles which is remaining in the oral cavity, so there will be the accumulation of bacteria on the surface. So the epithelial cells they produces on the bacteria, they produce the peptides or the proteins, and there is a presence of putrefaction products, and which will cause or which will lead to the oral malodor. Now, coming to the diagnosis it can be done into two. That is, first is a self-assessment, that is a subjective test, which is the first one is a wrist lick test, spoon test, the dental floss test, and the saliva odor test. In this test, the patient has to spit in a spoon, then they have to use a dental floss, and the saliva it has tested from the with the doctor, and the rating will be given that the halitosis is present or not. The next is the objective test, into which the first is the organoleptic measurements, gas chromatography, the sulfide monitoring, electronic nose, and the Bana test. So the first, coming to the organoleptic measurements, it is considered as a gold standard, which is given by Rosenberg in 1991, and it has been given a scoring of 0 to 5. Okay, so whenever there is a scoring of 0, so we can appreciate that there is no appreciable odor. Number 1 states that barely noticeable odor. 2 states slightly but noticeable odor. Third is moderate odor. Fourth one is strong odor, and fifth is extremely foul odor. Now, next, coming to the volatile sulfide monitor, it is an electronic device which analyzes the concentration of hydrogen sulfide and methyl mercaptan, but the volatile sulfide monitor, it is not able to discriminate between the both of them, that which one is present. It will just tell the amount, the presence or the absence of volatile sulfur compounds. The examples of this electronic device, it is the halometer and the interscan. The next is the gas chromatography. It measures directly the 3 volatile sulfur compounds, that is the methyl mercaptan, the hydrogen sulfide, and the dimethyl sulfide. Device can analyze air, saliva, clavicular fluid for a volatile components. Now, the next one is the electronic nose. This was given by Tanaka et al. Used for this, this uses the electronic nose to clinically assess the oral malodor. It is a sensing system, and it has a pattern recognition system. So the test, it is very clear that the halitosis is present or not. The next is the Bana test. It detects the presence of Treponema denticola, B. forsythus, and Pribotella gingivalis. The next is the Miyazaki et al. In 1995 has given a tongue coating index. So whenever there is a presence of a white coated tongue, we can divide into and we can score it from the 0 to 3 number. So 0, wherever there is a 0 number, So there will be no visible coating present. One states that less than one third of the tongue dorsum is covered. Two is between one third to two third, and three is more than two third of the surface is covered by the coating. Now, what are the preventive measures for halitosis? The preventive measures, rather than the curative aspects, are highly recommended. So, first, visit your dentist regularly. Periodic tooth cleaning and the dental professional cleaning it is required within 6 months. Then, brushing of teeth twice daily. Use of the trunk scrapers, flossing and brushing is required. Limit the intake of the strong odor spices and drink plenty of fluids so that the bacterial surface in the food particle is not present and there will be no accumulation of the bacteria on those surfaces. The manner now coming to the management of halitosis. So whenever there is a physiological halitosis, treatment needs one. It is done. That is the explanation of the halitosis and instructions is given to the patient, and oral hygiene is given to the patient. Then the oral pathological halitosis, it consists of treatment needs one and treatment two, which is the oral hygiene measurements is given to the patient, and the second TN2, it is oral prophylaxis, professional cleaning, and treatment of the oral diseases, especially the periodontal diseases. And whenever there is a pseudohalitosis, treatment 1 and treatment 4 it is given. The treatment 4 it is that the explanation of the halitosis, then further professional instruction is given, and education and measurements it is given along with the scaling and root planning. Then, however, when the treatment of the external pathologic halitosis is present, that then we refer the patient to the physician. That is a treatment number 3. Or if the halitophobia is present, then the treatment number 5 it is given. That is, the patient it is referred to the psychologist or the psychiatrist, and it should be undertaken by the physician itself. So the management of oral malodor, for the first one is the mechanical reduction of the intraoral nutrients and the microorganisms. The second is chemical reduction of the oral microbial load. Third is rendering malodors non-volatile gases, and masking the malodor. So coming to the conclusion, it's a common complaint that may periodically affect most of the adult population. Oral malodor, which is commonly noticed by patients, is an important clinical signs and symptoms that has many etiologies which include local and the systemic factors. The identification and underlining may help in reduction of the bad breath. Thank you.